Rason sa bunga nagkanto ka di?
Balidok daw, hindi ko na gusto magpalayo sa akong kabuhi. Balidok, mga kauna, may pagigna kang pumatsyagan. Pero 3 months ago, nag-start nga nag-quarantine, kagdamo na nga nagtago.
To bite me. Burr, frozen. You the one being chosen. Play the part like Moses. Keep it fresh like roses. Looks so good, yeah, looks so sweet. Looking good enough to eat. Clothes with the kiss, so we call me ice cream. Catch me in the fridge.
Good morning, Nay!
Good morning, anak. Kamusta ikaw, da?
Okay, good night. Nag-prepare na ako breakfast. Nagtinapay ko pag milk this morning.
Wow, gusto mo ginaadi. Ano klase mo karon?
Mga 9 a.m. Nay, nag-prepare naman ko gamit ko. Okay, ready to go naman ko, Nay.
Mayo. Din nakatuon na ikaw kang gabi.
Nakabasa man ko, Nay. Okay man siguro. Prepared naman ko sa quiz,
Di mayo. Hindi mo magalintan ni mo. Ano ha, bal. Tapos, panyaga ka, mayo. Karon na?
Okay, Nay. Thank you,
Taon
Nay.
tayo.
Si Nay, malakat na ko, Nay, ha?
At sige,
Tawag
halong
kita.
gida
Sige,
na.
Nay. Ay, wala naman yung klase. May quiz pat na tani. Sige, tawagan ko lang pagit si Nanay. Hello, Nay.
Ano na?
Nay,
Kamusta ikaw, da?
okay man, Nay. Bali na yung nagbalik, nag-chat, nag-video call lang pagit ko sa imo kay wala kami klase subong. Bali may quiz kami tani, wala man gyap man dadayon, di ba? Kay may 2 weeks nga cancellation to sa klase, Nay.
Ay, oo, nabatian ko na sa radyo ka inati. Kamusta, da? Hindi ka mapuli?
Nay, hindi lang po siguro kami mga exams pa kami kasi after 2 weeks mag-okay naman tanan. Hindi rin ako daliguro sa city.
Sure ka?
Oo, Nay.
Siguro ka mapuli ka?
Sige lang, Nay. Kaya man 2 weeks lang man. Kag mag-grocery lang ko later kung if ever nga hindi ko makagawa sa boarding house.
Oh, sige, di may allowance ka pa, da?
Sige, Nay. Okay pa, Nay. Oo, Nay. May ala pagid ko.
Sige, mag-call lang ikaw ha, kung mag-text na ikaw per me.
Sige, Nay. Update na lang pagid, Nay. So, anong gatapos sa akin diri. Thank you, good, Nay.
Sige. Okay.
Shoes on, get up in the mood, come on, let's rock and roll. King Kong, kick the drum, running on like a rolling stone. Sing song with. I'm rocking out to
Oh? May ara kami. May notification calling sa school. May ara kami online classes. Bali, more than 2 weeks pa rin ganinin nga wala. Hindi kami magkanto sa school.
So good morning everyone. Good morning class. So today we have our psychiatric interview history and MSE. So doctor-patient relationship is the core of practice of medicine. It is important to understand the nature of relationship, factors that influence, and the manner in which it can be achieved. So there must be support, understanding, and trust
Ay, ano naman ang
with the
online
patient.
So, itong magtanay sa mga classmates ko.
Excuse me, Miss Dubria, your microphone is on. Please turn it off.
Sorry, Doc.
Uy! Hi, Len! Nanghimus na ko, Mapulit na ko sa Dawanglas. 2 weeks daw wala klase. Tiimbag ni Mama. Malapulingan ako kasi yung siradong borders, budlayan kung mga puli. Himus ka na lang, sabay ka na lang sa akong sa terminal.
Sige lang. Nagkamala ko yung kagina kay nanay nga hindi ko naman puli. Kaya basta matapos man ni ang for 2 weeks tapos mabalik ka man sa klase. Kung if ever, bubayan ko mag-commute.
Ay,
So,
di, paano
ang
nga? Isa ka na lang di sa doon. Bilong ka doon, naka
Ay, sige na kaya. Naka-grocery na ako din. No, secure
Sure
na
ka?
yung pagkain. Oo, yes.
Sure ka, okay ka lang din?
Yes. Thank you, Gid. Halong ka, Gid, sa biyay.
Text ka ha, tawag.
Sige,
May
sige.
kailangan ka ha.
Thank you,
Bye-bye.
Gid. Thank you, salamat. Ay, may assignment naman kami. Okay, done na. Nakapas na. Bago naman bala. Subong. Check ko din. Oh, may assignment pa din kami. Okay, send. Hi guys! Kamusta ka mo?
Uy, long time no see.
Amo gani ka dugay na gid niya online class naton.
Gani, subo-subo, gid ya.
Gani ka boring pa binas ang klase natin kalawit sa 3 hours.
Sakit na gid sa buli ya.
Oo. Pab, kamusta ka Pab?
Gusto naman guys. Okay naman ko.
Okay gid.
But guys, kasi gusto niyo mag-inom,
Ay,
online
perfect.
siya
Pwede
ta.
gid.
Ay, perfect guys. Naali ko din yun na ano gid, in store gid. Tada!
Mawari.
Diba? Corny na digit ko ya.
Grabe ka.
So guys, ready na? Meron ako mga baso?
Oh, may baso na baso.
Oh, pwede gid. Ready na ko. Guys!
Kampay!
Go. So guys, daw solve na ta sa bunga.
Ikaw lang nasa
Bali, tama na ni. Kay may class na tabuas.
Amo man, amo gid.
Sige guys,
Paway na ta.
Sige guys, bye-bye.
Sige, bye-bye.
Bye-bye.
I see your monsters, I see your pain. Tell me your problems, I'll chase them away. I'll be your lighthouse, I'll make it okay. When I see your monsters, I'll stand there so brave and chase them all away.
Hi, Tay.
Hello?
Tawag ka, Tay.
Na, kumusta ka na?
Okay man, Tay. Sige pa man online class, subong.
Oh, kumusta ka lang sa inyo? Naka-adjust ka man tayo.
Siguro, Tay, kakaduga yun. Nagka-adjust naman ko, ah.
Pati ko, damo pati akong case niya sa Iloilo.
Oo, Tay.
Sa
Increasing yung active cases, Tay. Wala na point pag sa boarding house.
Te, kamusta ka da? Kamusta yung kuhan? Okay ka man? Hindi ka mong gagot man? Katulog ka man makayo?
Okay, good, Tay, ah. Tay, di kamusta yung pag-ubra dila, Tay?
Amo gani problema subong na kay tungod sa COVID kay ipauntat mi trabaho nanay. Tay, may chance sa pagid nga papulion kami diya sa Pilipinas. Kaya wala nang idawubra kay makat daw kuno sila sa employees diri sa Saudi.
So, ano, tayo, abe, ang kanyang pag-eskwela, tay. Pwede man tayo tapusan ko na lang di ang isa kasem kag magbulig na lang po sa inyo kung pagtapos eh.
Ay, nakasensya gida kay kapudlayan mong gitsubong mangitag trabaho mas asa kay tumunod ng pandemic wala.
Sige tayo, okay lang tayo ah. Sige tayo, kay may himuon.
Halo pa kita, Birme ha.
Oo tayo, ikaw man tayo, halong gidira. Sige tayo ah. May himuon pa ka tayo. Sige, bye-bye.
In the dark, we stand apart. We never see that the things we need are staring right at us. You just wanna hide, never show your smile. Stand alone when you need someone. It's the hardest thing of all that you see are the bad memories. Take your time and you'll find me. I see your monsters, I see your pain. Tell me your problems, I'll chase them away. I'll be your lighthouse, I'll make it okay. When I see your monsters, I'll stand there so brave and chase them all away. I can see the sky beautiful tonight. And when you breathe, why can't you see that the clouds are in your head? I will stay near, no need to fear. And when you need to talk it out with someone you can trust, what you see are the bad memories. Take your time and you'll find me. I see your monsters, I see your pain. Tell me your problems, I'll chase them away. I'll be your lighthouse, I'll make it okay. When I see your monsters, I'll stand there so brave and chase them all away. I'll chase them all away. You've got the chance to see the light, even in the darkest night. And I will be here like you were for me. So just let me in. 'Cause I see your monsters, I see your pain. Tell me your problems.
Ne, kamusta ka da, Ne?
Ano ka nito?
Waay lang, Ne. Mangumusta lang ko tani. Kay daw kadugay na sa imo guwa bala. Kamusta ka da?
Tulog lang kita dito. Okay naman dito ha. Hindi naman pala space sa akin doon.
Tiga kaon ka man da.
Wala kang gana to. Pero okay na to kay may available mo kung pagkaon kung magutom lang. Ang lang na pagkaon ko.
Sige, Ne ha. Tawagon mo lang ako, may kinanglan ka.
Sige to. Sige to.
Sige.
Sige to.
Tawagan ka bali ni nanay niya. Hello ma'am, maayong aga. Ang landlord ni Helen, ma'am. Ang bata mo bala, ma'am. Wala na ni guwa-guwa bala sa iyang kwarto. Dugay-dugay na. Daw na worry lang kami diri sa apartment kay wala na siya guwa-guwa. Pwede mo siya matawagan, ma'am. Makamusta mo siya tani? Sige ma'am ha. Salamat, gid. Ay, ang ano gali? Ang renta niyo gali isang boarding house ni Helen. Paki-follow up ko lang sa inyo. Sige Thank you, gid, ma'am. Sige, bye-bye.
Morning, Nay.
Kumusta ikaw na?
Okay man, Nay. Pero subong na daw kaiba gid sa akong pamatsyagan.
nag-istoryanay kami gali kang kapons ng imong nga landlord, ang bayan ko, wala ikaw kakaon, wala ikaw kakagwa dala sa imong room. Ano
Kay
to?
subong na daw, ibagid niya nga daw, budlay na daw, hindi na kung dalaluyahan ako kung mabuta ko sa aga, tapos kisado. Wala na sense kisa nga dumisip ko nga daw, hindi na daw, wala na sense magbuhi diri daw na na.
Wala na. Ano na? Nagkakabala-kali kami sa tatay mo sa iyo. Tulain na gina. Try mo yung pa-check up sa doktor na.
Pwede man na kayo daw may lapit man diri, okay, bid na yung kayo sa hospital, pwede man na lapit naman diri yung hospital na yun.
Oo. Di, saan ka magpa-check up di? Kung kulang yung budget. Padala na ka dayon.
Ay, ti salamat kid na yun. Ti sige na yan, magpa-schedule ko kay Doc sa aking check-up na yun. Thank you,
Okay.
gid na yan. Thank you, gid na
Sige,
tinagtawag
balitaan
ko.
mo din ko ha.
Sige na yun. Thank
Balitaan mo
you,
din
gid.
namin. Sige, bye-bye.
Bye, Nay.
So, bali ma'am, makuha lang ko mga vital signs mo, ma'am, ha?
Sige, Doc.
So, bali ma'am, makonduct lang po ma'am ka mental status examination. So,
Okay, Doc.
So for the mental status examination, the patient has a tiny build, stoop posture, downcast gaze, and wears a shirt and pants. She is cooperative with a decreased rate of movement. For the speech, she has a decreased rate and volume of speech. For the mood, she is depressed. And for the affect, it is congruent with the mood. For the thought process, she has a goal-directed and linear thought process. For the thought content, it is positive for suicidal ideation. For perceptual disorders, she has negative for hallucination, depersonalization, and derealization. She is alert, oriented to person, place, and time. She has a good concentration and an intact immediate, recent, and remote memory. She has an intact calculation, fund of knowledge, and abstract reasoning, and a good insight as well as good judgment. So this is the case of patient HD, 26 years old, single, Filipino, Roman Catholic, a medical student, and a resident of Negros Occidental. The patient went for consultation by herself with the chief complaint of matsyag ko, daw di na ko gusto magpadayon sa kabuhi ko. 3 months prior to consultation, patient started to have depressed mood accompanied by difficulty of initiating and maintaining sleep. Other associated symptoms include loss of appetite, social withdrawal, fatigue, loss of energy, excessive inappropriate guilt, and recurrent suicidal ideation. The symptoms was enough to cause significant impairment in social functioning. In an attempt to elevate her symptoms, she turned to alcohol in order to improve her mood and induce sleep. The patient did not manifest any psychotic symptoms as well as symptoms of mania or hypomania, thus satisfying the DSM-5 criteria for major depressive disorder. However, psychiatry is an ever-changing and evolving field of medicine. On follow-up visits, we constantly monitor for additional symptoms that may occur, such as mania or hypomania, as well as psychosis. Thus, we consider schizophreniform disorder and bipolar mood disorder as our differential diagnosis. Because patient has recurrent suicidal ideation, this qualifies as a psychiatric emergency. Thus, we will be admitting this patient for the management. For the management, we can start the patient with combination therapy of pharmacotherapy and psychotherapy. For pharmacotherapy, we can give either tricyclic antidepressant, selective serotonin reuptake inhibitor, or serotonin and norepinephrine reuptake inhibitor. Due to less side effect, Serotonin norepinephrine reuptake inhibitor is the best choice for the patient, which includes your venlafaxine, desvenlafaxine, and duloxetine. Starting dose for venlafaxine would be 37.5 milligrams per day with the usual dose of 75 to 375 milligrams per day. Continuous monitoring in the succeeding months for the effectivity of the drug as well as emergence of adverse reaction.
Hello, ladies and gentlemen. Good evening. And for tonight's medical podcast, brought to you by your boy Balot, we're going to talk about depression. So, let's get it on. So, depression or major depressive disorder is a common and serious medical illness that negatively affects how you feel, the way you think, and how you act. Fortunately, it is also treatable. Depression causes feeling of sadness and or loss of interest in activities once enjoyed. It can lead to a variety of emotional and physical problems and can lead to person's ability to function at work or at home. So how common is depression? In the most recent surveys, major depressive disorder has the highest lifetime prevalence of almost 17% among other psychiatric disorders. So that's quite high. And for the causes of your depression, it can be brought about by your biologic factors, genetic factors, and psychosocial factors. For your biological factors, we always talk about the importance of the neurotransmitters involved. So we're going to talk about the three major ones, your norepinephrine, serotonin, and dopamine. When these three neurotransmitters are actually increased, these cause symptoms related to mania. However, in depression, what they have noticed is that these three neurotransmitters have been in low levels. Other noteworthy neurotransmitters involved would be your acetylcholine, your gamma-aminobutyric acid, your glutamate, your glycine, and your N-methyl-D-aspartate. Also, studies have shown that there is actually an alteration in hormonal regulation when it comes to your depression. Most commonly seen would be the involvement of your brain-derived neurotrophic growth factor. Also, the disruption in your hypothalamic pituitary axis, which causes an increase in your corticotropin-releasing hormone, therefore increasing your ACTH or your adrenocorticotropic hormone, which therefore increases the production of your cortisol in your adrenal glands. Also, we can see an increase in your thyroid-stimulating hormone because depression is attributed to hypothyroidism. Growth hormone, however, has seen to be in low levels because your corticotropin-releasing hormone actually has an inhibitory effect to your growth hormones. So, sleep as part of your biological factors is very important. When it comes to sleep disturbance in depression, it can actually go both ways. We can see either insomnia or hypersomnia. And we can see sleep disturbance in about 40% of your outpatients with depression and as high as 80% for patients who are inside the hospital. Now, because of the increase in your cortisol, as mentioned earlier, depression can actually cause immunologic disturbance, more specifically related to the altered immune function. Cortisol inhibits the proper function of your immune system, which predisposes a depressed person to infections and other diseases. Genetic factors is a very important factor to also mention. Depression has been linked with strong familial linkage as seen in family studies wherein if one parent has a mood disorder, there is about a 10 to 25% chance for someone to actually incur mood disorder as well. And if both parents are actually involved, this can actually double the risk. For adoption studies, if one of the first-degree relatives have a unipolar disorder, there is a twofold increased chance. And if that first-degree relative actually has a bipolar disorder, then the chances goes as high as threefolds. In twin studies, they have shown that about 70 to 90% chance of incurring mood disorder if the twins are monozygotic, and just as low as 16 to 35% for dizygotic twins. And in linkage studies, they have isolated chromosome 18, 21, and 22 to be a loci for your mood disorders. For psychological factors, life events and environmental stresses are actually very important. Four noteworthy things have been proven to be related with mood disorders, specifically depression. such as your losing of parents before the age of 11 years old, loss of spouse, unemployment, and guilt. For psychodynamic factors, there are a lot of psychodynamic factors and theories involved in this aspect. However, one that I would like to actually mention would be from Edward Weibring. Regarded depression as a phenomenon that sets in when person becomes aware of the discrepancy between extraordinarily high ideals and the inability to meet these goals. So that's why you can see depression more common in those people who are high achievers, because when they are unable to meet their goals, this leads to depression. Now, people with depression actually experiences a lot of symptoms. Some we can see in the clinical study that was presented earlier. However, what's more important is that we learn how to treat these depressed persons. So in treatment of depressed people, we have to always consider hospitalization first. Illicit history of suicidal ideation. If a patient actually has suicidal ideations or has successfully committed suicide before, then definitely that's a clear indication for hospitalization. Other therapy that we can employ would be your psychosocial therapy, cognitive therapy, interpersonal therapy, behavioral therapy, psychoanalytic-oriented therapy, vagal nerve stimulation, transcranial magnetic stimulation, phototherapy, and of course, your pharmacotherapy. So choice of antidepressant is determined by side effects profile, these objectionable to the patient, patient's physical status, temperament, and lifestyle. And of course, we have to consider the cost to the patient. The most common clinical mistake leading to an unsuccessful trial of an antidepressant drug is the use of too low a dosage for too short a time. Unless adverse events actually occur that prevents it, the dosage of antidepressants should be raised to a maximum recommended level and maintained at that level for at least 4 to 5 weeks before a drug trial is considered unsuccessful. Alternatively, if a patient is improving clinically on a low dosage of the drug, this dose should not be raised unless clinical improvement stops before maximal benefit is obtained. When a patient does not begin to respond to appropriate dosage of a drug after 2 to 3 weeks, clinicians may decide to obtain plasma concentration of the drug if the test is available for the particular drug being used. The test may indicate either non-compliance or particular unusual pharmacokinetic disposition of the drug and may thereby suggest alternative dose. For treatment of depressive subtypes, patients with major depressive disorder with atypical features may preferentially respond to the treatment with monoamide oxidase inhibitor or selective serotonin reuptake inhibitors. Antidepressants with dual action in both serotonergic and noradrenergic receptors demonstrate greater efficacy with melancholic depressions. Patients with seasonal winter depression can be treated with light therapy. Treatment of major depressive episodes with psychotic features may require a combination of an antidepressant and an atypical antipsychotics. Several studies have shown that electroconvulsive therapy is effective for this indication, perhaps more effective than pharmacotherapy. For those with atypical symptoms features, strong evidence exists for the effectiveness of your monoamide oxidase inhibitors. Selective serotonin receptor inhibitors and bupropion are also in use in atypical depression. When initial treatment is unsuccessful, switching to an alternative treatment or augmenting the current treatment is a common option. The choice between switching from initial single treatment to a new single treatment as opposed to adding a second treatment to the first one rests on the patient's prior treatment history, the degree of benefit achieved with the initial treatment, and patient's preference. As a rule, switching rather than augmenting is preferred after an initial medication failure. For the course and prognosis, about 50% of patients having their first episode of major depressive disorder exhibited significant depressive symptoms before the first identified episode. Therefore, early identification and treatment of early symptoms may prevent the development of full depressive episode. Although symptoms may have been present, patients with major depressive disorder usually have not had premorbid personality disorder. The first depressive episode occurs before age of 40 years old in about 50% of patients. A late onset is associated with absence of a family history of mood disorders, antisocial personality disorder, and alcohol abuse. Many studies have focused on identifying good and bad prognostic indicators in the course of major depressive disorder. Mild episodes, the absence of psychotic symptoms, and a short hospital stay are good prognostic indicators. Psychosocial indicators of a good course include history of a solid friendship during adolescence, stable family functioning, and generally sound social functioning for 5 years preceding the illness. Additional good prognostic signs are the absence of comorbid psychiatric disorders and of a personality disorder, no more than one previous hospitalization for major depressive disorder, and an advanced age of onset. The possibility of a poor prognosis is increased by coexisting dysthymic disorder, abuse of alcohol and other substances, anxiety disorder, and history of more than one previous depressive episode. Men are more likely than women to experience chronically impaired course. So basically, this concludes our podcast for this evening, and I hope for you guys you've learned something this evening. And if you know someone who's undergoing depression, please let them know. We can talk. And remember, there's no health without mental health. Have a great evening.
So this concludes our case presentation. Now we can move for the question and answer and feedback portion. Hope you learned something and enjoyed our presentation.